This is about aging spine, and if you look at the vicious circle in fractures in the elderly, it's obviously that as age increases, bone density usually decreases, and then we have these fractures of the spine, of the hip, humerus, wrist, pelvis, whatever, and that, of course, is another reason for increasing the frequency of falls again. If you look at the epidemiology of cervical spine fractures, it gets evident that above the age of 65 years, these injuries are much more pronounced and more common in epidemiology than with the lower years. And if you look at the upper cervical spine injuries, it's almost 70% of all cervical fractures in the elderly. So we are dealing basically in the majority of all these cases with upper cervical fractures. That would be odontoid fractures, traumatic spondylolisthesis, fractures of the atlas, fractures in Encke's bond. And I would like to share some cases in all of these pathologies with you. So let's start with the odontoid fracture. This is simply a multiply injured patient. And this patient is not doing well due to this additional injuries he has. And there's no reason to think a lot about complicated MIS procedures, about navigation procedures. This needs a straightforward target and a standard surgery, and this is what we did here, and this is the post-op X-ray. So it's not fancy, it's just standard stabilization in a multiply injured patient. But then there are specific fracture patterns that deserve a closer look, and we find them especially in octogenarians. If you look at this patient here, this is an 89-year-old male patient with a seemingly pretty easy forward-going odontoid fracture. But if you look more closely, you also find, in addition, a fracture of the anterior portion of the C1 arc. And if you look even more closely, you see that this patient, of course, has pre-existing degenerative changes, like the spondyloarthritis between the C1 ring and the odontoid. And this is very conclusive in these octogenarians, and that's what, if you have a close look at this, what we call unhappy triad of C1 C2, you will keep seeing it over and over again. So this unhappy triad consists of a very proximal odontoid fracture, an either anterior or posterior fracture of the C1 arch, and a pre-existing degenerative status as anterior spondyloarthritis C1 C2, which is interesting because it means that these patients almost had an ankylosis already between C1 and C2, meaning they were rather unable to left-right rotate their head. And if you ask them for the history, they would say, yes, that's true. I realized I could almost not rotate my head anymore before the injury. This finding is important because at the same time it means you can go for a stabilization technique that does not necessarily need added fusion because it's ankylosed almost already before the trauma. This is just another case showing this type of what we call unhappy triad of C1 C2. An 83-year-old female, as I said, it happens with the octogenarians almost all of the time. And look at this situation here, a very proximal, almost the tip of the odontoid is fractured, and you see in addition the fracture of the anterior portion of the C1 ring, and you see that the C1 C2 joint is almost ankylosed. And this is a recommendation how to treat it. Again, this is only a screw insertion. The percutaneous mini-open screw insertion. You can do that with navigation. You mount your reference clamp on the Jackson table, and then you can go forward and can do that. It's not a fusion, but fusion again is not needed in these cases because the C1 C2 is already ankylosed. This technique was described as early as 1971, and it's basically nothing else than an anterior transarticular C1 C2 transfixation. Another patient, 81 years old, again, fracture of the anterior arc, a very, very proximal fracture of the odontoid, and a C1 C2 arthritis. This time we used 2 screws in the odontoid and 2 other screws to anteriorly transfix the C2 C1 joint in a navigated way. This is a lady on day 1 post-operatively on her 82nd birthday, and seemingly she seems to be quite happy with the surgery. What is the nice thing about that minimally invasive type of computer-navigated surgery? It is less traumatic and it has the same stability, given that you have this ankylosed situation between between C1 and C2. Let's go to another topic, that is the traumatic spondylolisthesis. That's just a case in a 64-year-old. CT scan preoperatively. If you classify it, it will be an Effendi 2. And this can be done very nicely in a minimally invasive procedure. Mini open posterior. You have the reference clamp fixed directly on the spinous process of C2, and this is a direct osteosynthesis of this vertebral body. And you have those 2 screws in. That is a perfect stability in a minimally invasive way that is easily being performed and achieved with the use of navigation. Fractures of the atlas. There's some criteria for instability, you know this. And this is a patient that was initially treated conservatively. This patient had his halo vest for 4 months. And after those 4 months, this is a situation in the CAT scan. So this is obviously delayed union. It's non-union basically already. And you see that the C1 ring is not consolidated, neither on the left side nor on the anterior portion of the arc. I would rather say there's a big gap. It's almost like an open book, what we see in the pelvis. I would describe it a little bit, this gap, like an open book of C1, of the C1 arc. So this needs to be closed in order to gain a fusion here. And one concept now would be a transoral approach, because by doing so, again, you can use navigation with this approach, having the reference clamp fixed on the Jackson table, and then you can insert your screws and you can close this ring with the rod, and it then went on to nice fusion. This is another type of injury with a G-value 3B, with dislocation in a patient that has reduced bone quality. And this is another thing, of course, if we're dealing with these elderly people, we not only have to have a concept of stabilization that works in young patients, but we need to modify, we need to amplify sometimes our usual concept in order to take care for the reduced bone quality. So that would be the situation, and you see this is there's a dislocation of the atlas and the highly unstable situation. So this needs again a stable fixation, and that was achieved with this occipital-cervical fixation. That's the post-op. That's the patient. And finally, I would like to shed a little bit of light into the ankh-spont fractures that we see more and more often, also especially in that age group. Goes back to this gentleman here, Mr. Blattert, and that's just the first case in a 56-year-old. You see there, the patient did some correction a little bit. He gained a little bit of lordosis. So one of the concepts would be use that little bit of relordosis that the patient has, go for anterior stabilization, posterior stabilization, because these fractures are always pan-spinal fractures, and this is the corresponding MRI scan. If you have a look at the literature with ankh-spont, it is very obvious that the risk for initial neurological deficit is much higher than in any other type of injury of the cervical spine, and it is as a matter of fact, it is 11-fold higher than average. And also the risk of secondary deterioration of that neurological status is 14%. And this is why in these cases we use neuromonitoring. We heard a lot about that this morning. So initially having this anterior fixation done, and you see we don't try to close the gap. We just use the little gap. We just use that little bit of reload doses the fracture gave to the patient and insert a cage. When we flip the patient over and it from posterior, basically all it needs is a tension bend situation, and that can be easily performed with this posterior instrumentation. And this is already the 15-month follow-up. These patients, once they're fixed nicely and stable, they tend to heal very quickly and to fuse very quickly. That's the nice thing about it. Another situation in a patient with an Eng-Spont, this is a double fracture, and I would advise you to always go for a total spine in these patients, because in a high percentage you find multiple fractures in these patients. Like here, double side fracture in the cervical spine, 5 segments bridging from anterior. Motion preservation, of course, is never an issue with these patients because they're ankylosing. So you can go forward and you can fuse your 5 segments with an anterior fixation, and then it needs again, usually it needs posterior tension band. This can be performed nicely by, you don't have to open this hole. This is a long distance here from the posterior pair of screws to the from the cranial pair of screws to the caudal pair of screws. There's a long distance, and you don't need to have to open it entirely, of course. What we do is just we push the rod through the muscles and fix it in one screw and the other. So it's not really minimally invasive, but it's less invasive, and it's according nicely to the pre-requirements of this aging spine population. This is the situation at 1 year follow-up, at 2 years follow-up. So again, these Eng-Spont patients at least heal very nicely. If you look at the literature, it's also clear that usually they are doing better if they are being performed, if they're being stabilized with surgery, rather than having any efforts with halo vests or whatever. So the light gray column here on the left side is the surgical treatment, and the light gray is the ankylosing spondylitis. So this is what we are looking at. And if you look at post-treatment in the surgical treatment and mortality post-treatment and the conservative treatment side, it gets clear that mortality and morbidity in the conservative group is almost double as high than in the surgical group. Patient's doing nice, or he has gotten back a little bit of lordosis, so his vision is better than before. And in summary, I would like to, of course, focus on the fact that the principle of primum nil nocere is as true as always, also in this aging spine population. The leading, if not the exclusive indication for all what you do is achieve a pain-free situation for your patient. And that also includes that you should give the patient one shot, and then it should be stabilized and it should be ready, rather than doing any sophisticated things that might go into revision. Life before function, especially before radiographic beauty. Sometimes you need to be quick and bloody and fast rather than having a wonderful x-ray afterwards. Specific fracture patterns need to be recognized, as I was trying to show you that what we call unhappy triad of C1 C2. If you recognize specific fracture patterns and acknowledge them, you may realize that it's no longer necessary to do long constructs with fusion, because some situations are already fused due to degeneration. If it reduces morbidity and time of surgery in your hands, you can use navigation. It's a helpful tool. If it lengthens time of surgery, you are at the beginning of the learning curve, and you should, and that's certainly a very important point, never attempt to get your surgical learning experience from that group of patients. At the end of my talk, I would like to invite everybody here to the Eurospine Spring Specialty Meeting that has been held next year in Frankfurt. Frankfurt is easily accessible from Jeddah with the one-night direct flight. Frank and myself are hosting it, and we're hopefully looking forward to see a lot of faces that I see here. Thank you again for being here, and thank you again for your attention.